Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today we have Dr. Manju Sengar, who is a leading authority in India in the field of hematological cancers and working at probably the top cancer center in the country, a long legacy, Tata Memorial Hospital in Mumbai. I'm privileged to be able to speak to her today. And we're going to just give an Indian flavor to diffuse large B-cell lymphoma. So Manju, welcome.
Thank you. Thank you so much for making me part of this initiative. Really pleased to be here, and thanks for those kind words. Thank you.
So Manju, so just to get started, so what is the entity diffuse large B-cell lymphoma, and how do you kind of tell your patients about what this is?
So, if we look at diffuse large B-cell lymphoma, it's a type of cancer which typically develops in the organ which harbor lymphocytes. The blood cells, one of the blood cells which we call as lymphocytes. So this is one of the commonest non-Hodgkin's lymphoma which we see. So practically, there are two types of lymphomas which we, see in our practice in broad categories. One is Hodgkin's, and of course, for the lack of better word, the other subset is called the non-Hodgkin's lymphoma. And amongst this, diffuse large B-cell lymphoma is the commonest malignancy. When we see these patients, the typical questions which are asked is, what is it? Whether it's typically a cancer or it's not a cancer, or it's just, in many times a layman's language, people do refer it to what we call as blood cancers. And the next question, which is there, whether it's curable or not. So typical answers to all these questions: yes, it's a type of cancer, the cancer which can develop in any organ which is harboring lymphocytes. And it's the commonest lymphoma, very treatable. Even in our setup, we get to see good results when we treat these patients who have non-Hodgkin's lymphoma of diffuse large B-cell type.
And even in the Indian context, potentially curable.
Absolutely. So these, even when we see diffuse large B-cell lymphoma and advanced stage disease, because the first line treatment, which is available for diffuse large B-cell lymphoma across the world, is also available in our country, and therefore it's treatable and curable in roughly 50% of all the patients who even come in the advanced stages of disease.
That's certainly hope for patients. So, how common is it? What's the profile of the typical Indian getting diffuse large B-cell lymphoma?
So, as I said, that it is the commonest non-Hodgkin's lymphoma, which we see in our setting. Given that we are at the tertiary care cancer centers, in a year we see close to 900 to 1,000 patients with diffuse large B-cell lymphoma. As is true for most of the cancers in India, the age at presentation is younger because we have our population demographics which is younger. And for us, most of these patients present in their early 40s. Having said that, it's not that we do not see the patients who are older than 60 with diffuse large B-cell lymphoma and even younger population. But majority of our patients would, the median age for our patients is going to be in their 40s. And if we look at how things have changed over a period of time, it could be because of better reporting systems which are there, but we are seeing gradually that the incidence is going up. But this could largely be the reason being that the reporting is much better, people present to the hospital, and therefore more diagnoses are being made.
So how does the typical patient present?
So the commonest presentation is that there is swelling, a lymph node swelling which comes up. It could be in the neck, it could be in the armpit, it could be in the groin. Sometimes the presentation can be outside the lymph nodes, and what in our terminology we call this as extranodal presentation, and that could be in the gastrointestinal tract. So it could be stomach, it could be the large bowel, it could be in the other areas like in women, it could be in breast, it could be in the adnexas like ovary, uterus. It could be in the testicular area, or any of, practically, as I said, that any organ which harbors lymphocyte can develop a diffuse large B-cell lymphoma. So it could be even in the brain. Um, Once it starts from one side, it typically spreads to the other side. When it's starting from one node, it can go to the other nodal area and the nearby areas. If it is starting in the organ, it can go into the lymph nodes, which are draining that organ, and it can involve the other sites like bone marrow, liver, etc., which makes it an advanced stage of lymphoma.
So how do you typically diagnose it?
So most of the times, the patients who come to us often have had a biopsy outside before coming to us. But people who haven't had a biopsy, we do a biopsy from the most representative side. So when I mean representative, that if we have someone coming up with the lymph nodes in the neck, we pick up the lymph node, which is reasonably big in size, appears to be involved by a disease, and we either do a whole node biopsy, meaning we take out the lymph node, or if the entire lymph node removal is difficult, then we take out a piece, what we call as incisional biopsy. Over a period of time, and as techniques have become much more better, there is a lot of times the needle biopsies are done, what we call as core needle biopsies. Uh, Even we have better advances, better ways of making diagnosis under microscope with core needle biopsies, but the preference always remains that if you get an excisional or a whole node biopsy or an incisional biopsy. However, this may not be possible when the organs which are involved are deep seated, and in that case, either under the guidance of a CT scan or an ultrasound, you do a core needle biopsy. And then this biopsy is sent to the pathology lab. They look at under the microscope after doing the regular staining. Um, Largely, the first suspicion is based on how these cells or how the lymph node or how that biopsy appears under the microscope. And once they have looked at this and suspect that there is possibility of a malignancy, and likely a malignancy which is of blood, that is lymphocyte, then they put certain additional markers, what we call as immunohistochemistry, to characterize these cancer cells better. And most of these diffuse large B-cell lymphoma, almost all of them would have what we call as CD20 expression. And it's important because that gives us an idea that this is going to respond or can be treated with treatment which has rituximab, which is anti-CD20 antibody. More and more, as we try and understand the disease better, we try and look at what is the exact subtype of DLBCL. So there are several non-Hodgkin's lymphoma. One of them is DLBCL, and within DLBCL, you have several categories. Most broad classification when we look at DLBCL is whether it's germinal center or whether it's activated B cell type, or we cannot classify it further. Or there are some more aggressive variants of diffuse large B cell lymphoma, what we call as double hit lymphomas or double expressor lymphomas. So special tests, what we call as immunohistochemistry, as well as at times certain molecular tests like FISH are done to characterize these lymphomas better. This is as far as the diagnosis is concerned. So we first need to know whether it's diffuse large B-cell lymphoma or not. Second step is we need to look at whether, where all the disease is, and that requires imaging. We prefer doing a PET-CT in these patients at diagnosis because it gives us better idea in terms of extent of disease, which organs are involved, and the size of individual sites which are involved, whether it's lymph node or whether it's particular organ. So it helps in accurately staging. Having said that, not every center in India may have accessibility to PET scans, and therefore even doing a contrast enhanced CT scan of the neck, chest, abdomen, and pelvis is good enough because that tells us where all the disease is. So these are typically ways where we do, how we do staging. In patients where we are looking at otherwise an early stage disease, we do tend to do a bone marrow examination to make sure that whether the bone marrow is involved or not. But if someone otherwise on a PET scan has already features showing bone marrow involvement or the extent of involvement is such that you call it as stage 4, then doing an additional bone marrow biopsy, does not make much value, and we can avoid that and we can continue with the treatment planning.
So how do you approach treatment?
So treatment, is largely based on, as I said, that we have access to rituximab, we have access to conventional chemotherapy, which is CHOP chemotherapy here. So it's a combination of rituximab and CHOP for patients who are fit. And when I say fit, it's largely when we look at elderly with multiple comorbidities, that's where the R-CHOP delivery may become difficult in our setup. But otherwise, it's an R-CHOP chemotherapy, which is standard for a typical diffuse large B-cell lymphoma. Things have become better because we have multiple biosimilars for rituximab. So in early 90s, when rituximab came in, our usage of rituximab for all DLBCL was probably less than 5% of all patients. And things have changed now in majority of the settings. And I can speak of, most of the cancer centers in India, that now the usage of rituximab has become almost close to 100%. And this is thanks to the biosimilars, thanks to the government through different schemes which government has, that we are able to use rituximab and CHOP for most of our patients. We, typically for an advanced stage, or what we call as stage 3, stage 4 disease, we give 6 cycles of rituximab and CHOP chemotherapy. It's reasonably well tolerated. However, our caution always is for patients who are going, because this is an outpatient therapy and the patient keeps coming back up once in 3 weeks, is to make sure that if there are any side effects, largely which can raise a suspicion for infection, to come back quickly. We do give them an idea of what to expect in the first week, which is typically nausea, vomiting, some bit of oral ulcers, constipation, and we make sure that they have enough supportive care medication which is available with them to manage this. But if there is any fever or excessive weakness, vomiting, diarrhea, they should come back as soon as possible to the hospital. Because if the patients present early, the treatment related complications with R-CHOP in a patient where where there are no other comorbidities, we don't expect what we call as treatment-related mortality with this. But if not, if the patient is unable to reach hospital, or if there are not been, the counseling has not been appropriate, then there is a risk of losing a patient who's otherwise curable. So that's something which we need to keep in mind, given that many patients go back to their homes and may not have immediate access for care when they develop these complications. So this is for the frontline therapy, but once the disease relapses, then in that case, we look at whether there is feasibility for transplant, eligibility for transplant, how long the disease has remained under control, and how well it responded to R-CHOP. Based on that, a salvage chemotherapy is planned, which is, again, combination of rituximab with one of the conventional chemotherapy agents, and then transplant. As far as transplant is concerned, things have improved over a period of time, but I must say that even till now, out of all the eligible population, the access to transplant or actual, transplant happening in these patients is probably not more than 15%. So that's something which we need to look, and see how we can improve. We have now, indigenous CAR-T, which has been developed here with the help of IIT Mumbai, and we did the clinical trials for this CAR-T. So for patients who are, where the disease has relapsed very early after the R-CHOP chemotherapy, or those who have failed transplant or failed salvage chemotherapy, we have access to CAR-T cell therapy now. And again, the important part here is that it's indigenous. It's much cheaper than what is there in the high-income countries. However, having said that, it still is a significant cost. So amongst all the eligible patients who would be eligible otherwise for CAR-T, the percentage would not be more than 15 to 20% who would actually end up receiving CAR-T cell therapy. And an important aspect would be that, most of these patients who receive CAR-T cell therapy, they develop hypogammaglobulinemia, meaning their immunity goes down after therapy. And again, in an environment where we live, where there is a lot of multi-drug resistant infection, lot of viral infections, overcrowding, etc. We need to be careful and have proper prophylaxis for infections as well as counseling when a person develops infection. What to do is very, very important in our setup when we manage these patients post CAR-T. So yeah, so that's about the overall landscape. We don't have availability of bispecific antibodies, which are becoming more and more prominent with respect to managing relapsed DLBCL in other parts of the world. We do try and procure these on compassionate basis, or we import through a named patient license. But again, the affordability is really, really limited for these bispecific antibodies.
I'm sure that will improve. These have become, indispensable part of therapy, and it's only a matter of time. I'm sure that access will improve. So you've gone over some of the challenges, but just what are, just to summarize in a way, the challenges you face in treating this in the Indian context?
So I think first and foremost is the for people reaching the healthcare facility. Oftentimes, because as I said, that the presentation can be very non-specific. It's a lymph node. The commonest thing in India when a person goes with a lymph node enlargement to a clinician or to someone who's closer their homes is tuberculosis. Though the course is much more aggressive here in the DLBCL as compared to Hodgkin's lymphoma, even then, sometimes the diagnosis get delayed because it's only a fine needle aspiration which has been done, and it shows some reactive lymphocytes, and therefore, they continue to receive some antibiotic or at times even antitubercular therapy. So I think having more and more people in the community who are aware that this could be lymphoma, coupled with expert pathologists. And what I mean is that, suspicion of lymphoma, we can do the rest of the workup in more central locations. But at least the initial suspicion, because, it's treatable disease, it's important. So I think increasing the awareness amongst more, peripherally located community centers as well as the healthcare centers which are there, in terms of that this could be a lymphoma which is treatable. Let's not treat it as TB and refer it to the next level. Of course, as I told you, that majority of the treatment, even till now, when we talk about hematological malignancies, delivered in more central location, more tier 2 and tier 1 cities rather than in the peripheral location. And therefore, to receive 6 cycles of ARCHA, people have to leave their house and stay in some another city for 4.5 months, which results in loss of livelihood. And at times, that results in treatment abandonment. Because when you give 1 cycle of chemotherapy, the lymph node goes, shrinks in size, and people start feeling better, and they feel that, okay, now they can go back, and they can just go back and continue with their regular work and, go back to their villages. So that's another issue that, we need to make sure that we make this therapy accessible even in the remote location. It can be through the telemonitoring and training the local physicians in a way that this can be delivered. Because except for the first cycle of R-CHOP, where there are infusional reaction issues, the subsequent cycles can be delivered provided the febrile neutropenia and other complications can be managed. The diagnostics, again, as I said, that if you look at these the bigger centers or the bigger cities, there is probably an overcrowding of PET scans, whether you talk about the private setup or a public setup. But as we go remotely, it's difficult. Even now, having a PET CT access, it's not the machine, even the nuclear medicine physicians who are limited in number who are going to interpret that. So I think access to these investigations is a problem. Molecular profiling, etc., which helps in refining the therapy to a certain extent as of now, largely from the double hit lymphoma point of view. So that's limited. But what I feel that, even if we are able to deliver R-CHOP to all the diffuse large B-cell lymphoma across the country, it would result in significant improvement in survival. It's the, subsequent therapies for the 50% who do not respond in a manner in which you want them to respond, or the disease where the disease comes back. those are the sets where the difficulties are much more because, as I told you, access to bispecific, access to transplant, access to CAR T cell therapy is there, but it's really limited even now. So I think we do need to build up like indigenous CAR-T. I'm hoping that there will be some indigenous bispecific antibody because I don't see in near future the cost from the typical innovators to come down so low that it would become like rituximab. Because even for rituximab, we took close to 8-10 years before we got the biosimilars in place and we could increase the access. And I think what is missing link with us is that we do have individual cancer centers running their database now with the Hematology Cancer Consortium, which we run with almost 32 cancer centers across the country. The knowledge on what is our burden of lymphomas overall, knowledge of how do they fare, is something which we need to know, and therefore these registries which are there, as part of the cancer center registries will help. But I think very important is that there should be much more strengthened population-based cancer registry to get fair idea of anyone who presents with the suspected diagnosis of lymphoma, what happens to them, what is their outcome, what is the stage, because that will help us in developing therapies and strengthening services in the area where we see these much more common, and or even to understand whether we have any differences in biology with respect to what is reported in the Western countries. So I think we've come a long way, but I think there is still a lot to be done as far as the treatment in our country is concerned for DLBCL.
Once again, I think you've hinted on several of these aspects, but anything you'd like to emphasize on opportunities and what future directions you hope the field goes in?
Yeah, so I think, of course, the most important if we start from is to know what is the current status. So we all feel happy treating patients who walk in our clinic, and we know that we have treated them, they are doing well. But what is happening to those who have not come to our clinic or have received half therapy somewhere or haven't been diagnosed? So I think that's the biggest gap because you have an effective therapy and it can be implemented across. It's just that we need to have a clear idea on what's our denominator for these lymphomas and what is happening to them. So I think, as I mentioned, that we need to have more effective cancer registries which capture this denominator correctly, and they capture from the population, not just from the hospital. And we can look at how the patterns of care of these lymphomas are in the community, because that's what is going to give us an idea in terms of what is needed to be improved much more than what it is right now. Biosimilars are something which we already have, but as I said, the biosimilars, and I'm being more ambitious here, biosimilars for bispecific antibody or an indigenous bispecific antibody, addressing the unmet need for the 50% who do not respond or relapse very quickly. And of course, the transplant, for the eligible patients, the transplant is another thing which needs to be strengthened. The transplant programs need to be strengthened, and their availability in smaller cities is something which is more important. More and more clinical trials. I think there are clinical trials which will come in from the pharmaceutical industry, bringing in novel molecules. But I think equally important is supportive care, thinking different strategies for our patients with respect to what can be done for improving the first line treatment, whether we can bring in the molecular profiling, better monitoring to identify the patients who are likely to relapse early on, and then treating them with a different therapy or intensifying their treatment. So we need to think through several of these issues, because once the relapse happens, the challenge is that again you have limited access for subsequent treatments. For any disease, and lymphomas are no exception, I think it takes a village, and we need to have a collaboration amongst everyone who's involved along this chain, starting from the remote, health centers, community health centers, the government, the NGOs, who are going to advocate for patients to bring in some of these therapies within their reach is something which is very, very important. And of course, uniform guidelines, because not everyone requires 6 cycles of R-CHOP, not everyone requires radiation therapy, and not everyone would need a CAR T cell therapy. So I think it's important that the guidelines are adhered to and the treatment is done accordingly.
So, what would your parting words of wisdom be for our audience today?
So my so as I said that I'm very hopeful that things are going to change for better in diffuse large B cell lymphoma. It's already one of the cancers where we feel that the outcomes are good, but we there is still something more to be done. So I'm very hopeful that we will have many more therapies. We will treat the patients with much more precision or much more individualization of therapy as we move forward. And there are ways to do that, and some of them are in advanced stages of clinical trial. um, we do see much more advanced disease burden, but even then, we this is something which is treatable with more than 50% cure rates. However, it's important for us as oncologists to understand what are the important differences which we have in our country as compared to the West. And we need to train more and more people, not just the medical oncologists or hematologists, but more of pathologists to make sure that the diagnosis is done on time and correctly. And I think this is one disease where one can have huge collaboration, not only within country, between different stakeholders, but even across the continents, because we can bring in the newer therapies, newer technology much faster through these collaborations.
Well, I wish to thank you very much for taking the time to educate our audience about the status of diffuse large B-cell lymphoma here in India. And I hope that I can turn to you for education on other topics and updates as the field moves forward.
Thank you. Thank you so much. And I hope that it made some sense. Thank you.
It certainly did. Thank you very much.